today we are joined by Jenni Burton, Dr. Jenni Burton, who is a clinical lecturer in geriatric medicine at the Institute of Cardiovascular and Medical Sciences at the University of Glasgow. Now, Jenni has had a very important contribution to understanding the impact of COVID on the population, on the people who live in care homes. And she has a very interesting perspective as she's both a researcher and a clinician. And Jenni, we're going to start by asking you a bit about what your job role was before the pandemic and what your research interests were before.
So thank you very much for the chance to have a discussion about this. So I'm a clinical lecturer, so my time was divided before COVID into 80% clinical work as a trainee in geriatric medicine, with a day a week for my academic work. And my interest in care homes was huge. I'm absolutely passionate about improving care and understanding of the population, people living in care homes, and how we can better support them. My PhD, which I finished in 2018, was all about understanding pathways into care. And that's really where my interest in data came from, because I thought it would be quite simple to work out who went into a care home and who went in from hospital and who went in from the community. And I stumbled on this huge challenge, which was, well, we don't know who lives in a care home from a data point of view. And then secondly, working to define these pathways actually was something that, although as a clinician it happens on a frequent basis, from an academic perspective, it really wasn't explored, and the data really aren't there in the way that you would think they would be to understand this quite common but really important transition of care. So a lot of my interest was in understanding the data sources, particularly in Scotland, and looking at how you might join them up to better understand things, and that's kind of where I was beforehand. I was also involved in a big study that Claire Goodman is leading that's funded by the NIHR, which is looking at developing a care home minimum data set to understand again what information care homes need to support their residents, but what information can then help enhance that in other settings. So stopping the duplication of data between the NHS and social care and helping understand the population much better. And all of this had really started long before we knew anything about coronavirus number 19. And then obviously as the spring of last year took place, from a clinical role, I was redeployed. So we moved from our specialty training to supporting the acute medical response, and so helping run high dependency, where in Scotland we've been giving a lot of the sort of CPAP aerosol generating treatments. So very, very different from my normal day-to-day role. And we were on a sort of special rota trying to support the very, very front acute end of the COVID response. But that I kept on pestering people about data in care homes. I really wanted to be doing more in the community, but with my training commitments, I absolutely had to be in the acute hospital. But that helped start a lot of conversations about, well, what could we be measuring and what data were there and how could we use them better, and led to some involvement in some more national work about how we could kind of join up what we do have, and also trying to highlight what we don't know and what we need to fix once and for all.
Yes, and understanding the impact of the pandemic and the scale of the impact, particularly in care homes, was a big challenge, particularly at the beginning of the pandemic, where, though, as you were saying, those data systems were not in place and we didn't have very good ways of tracking what was happening. And you have done some really interesting work on this in Scotland, and both, if I remember correctly, on a survey of care homes, so it was an analysis of data of care homes, and then you've taken that work forward to try and measure the impact in a way that was easily translatable. So would you like to tell us a bit about that? Perhaps we could start with what you found were the factors that were affecting the impact of the pandemic on care homes.
So we started off doing some work in NHS Loading, and this was led by Bruce Guthrie, who's a professor of general practice and based at the University of Edinburgh. And he and I have collaborated on a lot of things in the past, and he was much more effective at getting hold of regional data than I was. And so we looked at in the NHS Loading region, so that's around Edinburgh, but surrounding towns and cities around there, the whole health board to see the care homes who'd been affected by COVID, those who hadn't, and to really understand the impacts at that whole kind of population level within Scotland. And that was the first paper that really identified a couple of things. So firstly, the very, very strong influence of care home size as being a predictor of the likelihood of having an outbreak, and really showing the very big differences across the sector in terms of how care homes are organised and structured. But it also was the first to show the really different mortality impacts. So there's obviously been a lot of talk about how severely the sector as a whole has been impacted by COVID. But what you could see when you could get down to that service level data was the way in which actually the really devastating impacts were very much concentrated in the homes that experienced outbreaks. And it really just gave pause for reflection on how it would feel to be staff working in those homes, residents living in those homes, when you see the really, really devastating, particularly mortality impacts concentrated in such a small number of homes. Obviously, all the others were exposed to the same restrictions, the same changes in terms of their contact with families, but just seeing that kind of really devastating impact, I guess then did make you very worried about how we would then protect all those other services, and seeing really that actually lots of care homes were still very vulnerable, which unfortunately has been something that's been proven to be true as wave 2 and 2, 3, depending on how you describe and define it, have continued to evolve. But I think one of the really staggering things has been the difficulties of very basic things. So we know how many people have died with COVID on their death certificate, but we don't actually know how many people live or were living in care homes as this all started. So we have no idea what the true impact, and we'll never know exactly what population and what our denominator is. And that just, again, feels really, really stark and staggering, because we talk about the numbers, but actually putting that in context and understanding this population. One of the things that we quite often describe when I'm talking to people who don't know about care homes is that in Scotland and across the UK, there are lots more people living in care homes than there are in our acute hospitals. And in Scotland, it's more than 3 times as large a population. And if we compare our understanding and insights and what we know about those who've been hospitalised due to COVID, it's absolutely couldn't be streets apart different. So that piece of work was helpful, and actually was interesting in the releasing as a preprint. So it obviously went to preprint in the summer. The publication didn't make it out till the autumn, and it has been kind of pause for reflection as an academic about, I guess in the past we've always been a bit suspicious of non-peer-reviewed research, and certainly there's an awful lot of it in COVID, but it has really kind of focused the mind on the need to share some of these insights at an early stage, because those things about, say, care home size have led to Scottish Government advice being different about, can you isolate large care homes into discrete units? Can you operate them almost like they are multiple small care homes? And those practical things have actually been useful to homes and have allowed them to keep sort of functioning and operating, instead of some knee-jerk response of, oh, we just need to close all the big care homes, and the devastating impact that would have on residents. So yeah, that was the first bit of work.
So I'm going to ask a follow-on from that, because you have gone a bit further. So you, as well as doing the publication, you have also been developing practical tools to support, I think, both care homes and hospitals. Yeah. Do you understand correctly? And I think, again, this has been one of the big changes we've seen in the COVID pandemic, where researchers have gone the extra mile to communicate their work. So do you like to tell us a bit about that?
So I think this is one of those that combines, I guess, my clinical role and the research insights. So yes, you're right, there's 2 resources. So one of them is specific to COVID and is about collating those experiences from care homes about how they've looked after people and what things have helped support residents through this particularly difficult experience. And I was very keen to make sure that we got those perspectives in, because I think a lot of the guidance and things have been written more from a health and hospital point of view, and trying to understand that actually there's so much expertise in the sector itself, There's so much that they saw. So they were the ones who recognised non-specific presentation of COVID long before the academics did, because they almost say, cough, who coughs, in the sense of this. But that change in their residents' behaviour, the fact that they know them so well and they see those changes, and it's just been, I guess, making sure that that message gets out to care homes who haven't seen that and haven't seen that evolve. So there were those aspects about recognition. I think from a management point of view, recognising that so much of the management of patients in that, or residents in that setting, is actually about supporting them and supporting their basic needs and care, but also recognising and acknowledging the unpredictability of the virus and the propensity for it to cause mortality in this group, and acknowledging that openly, because again, we don't like to talk about what we can't fix. And I think sometimes it's been interesting for me in the pandemic, being in a very acute setting, seeing that even how, with all of the technology and resources that we have available, sometimes how we still can't stop people from dying from COVID. And I think just challenging that perception that somehow if someone dies, that's a failing on the care that they've received, as opposed to just the absolute devastating nature of this virus, but also recognising that the care that they receive and the support they receive is actually the most pivotal thing. But I think for staff, they've had to carry such a burden of that because of the visiting restrictions, that again, they're just doing the toughest job out there. And knowing how well supported we are, you just want more of that to go outwardly. But I think that's going to be longer term in terms of our models of care and support. So yeah, one of them was about supporting care homes and them sharing that best practice and getting that out in a very practical infographic and video format. The second one, I guess, came more from my personal experiences, that care home residents often present to A&E departments or medical receiving, and often the doctor who's assessing them is a bit at a loss as to how to make their assessment. And so that was really about providing some really practical, basic things, yes, fundamental things, I would say, about how you approach assessing someone and make sure that you give them the care and the assessment that they deserve, but also debunking some of the myths. So one of the big ones that I often see is it'll say on the handover sheet, care home refused to send member of staff, and everyone will go, that's terrible. You go, well, if you've got a care home that's staffed to look after your residents, you can't send someone away in the middle of the night to sit with someone in hospital for hours, but they'll always answer the phone and they'll be more than happy to tell you what happened. But in just the same way that the wards don't send their patients down to A&E to get assessed with members of staff, that just wouldn't happen. And I think just trying to understand better from both perspectives, acute care, often staff have never been in a care home, they don't know how things work. But if you can bring some of that information closer together, the end result should be that residents receive a better assessment, but actually there's more mutual understanding on both sides. And I think that's a big theme around the pandemic and some of the challenges, is that interaction between the settings. And we know that everyone is struggling, but understanding where those struggles are coming from and what we can do to ameliorate them, because you ultimately have to safeguard those individuals and those residents. And it may not be optimal for them to be in the wrong place, but you need to make sure that if they return home where they want to be, their needs can be supported and you're not exposing them to increased risk. But I think that's something that, I guess, even with the language of integration, hasn't really been tackled on the ground before. And what I'd like to do, I guess, is advocate for both sides, that we can come together and understand each other a bit better and actually work together to provide that holistic care across all settings. So kept myself busy.
Absolutely. And then you've gone a bit further and you've done one more step, which I think is extremely important, because we often talk about deaths of care home residents and as if, well, you know, they're so old anyway, it's almost inevitable. You see that quite often in the press. And you have actually done, and I think this is currently out as a preprint, a really interesting piece of work, but you're looking at the years of life lost among care home residents and looking at the sheer volume of that and the sheer impact of the COVID pandemic in those terms. So perhaps you could tell us a bit more about that. And I'd like to say personally, congratulations on thinking of doing this, because it's a much needed way of understanding the impact of COVID?
So I think one of the other fundamental things that we don't really know is about normal care home length of stay and normal activity through care homes. And that, again, as you say, leads to a lot of rhetoric around the sort of value, the impact, the true meaning of the pandemic. And I think one of the things that was helpful to do was then to look at that in a quantitative fashion and say, well, looking at the average length of stay, life expectancy based on then what's normal in non-pandemic times, and then looking at the very different impact, and you can very clearly see the absolutely devastating impact of wave one reflected in the data in terms of the disproportionate impact of COVID on those living in care homes. But then using that to show the mortality impact, so not just raw numbers, but as you say, the years of life lost, and therefore that the benefits of preventing infection in that setting are so huge in terms of saving lives. And we see that again with the risk to care home staff who've again been exposed in a way that frontline NHS staff have been, and the benefits of that. And I think one of the things has been, I think there is a bit of debate about in wider society about the impact, and I think just understanding how we can best protect people moving forwards is just really, really helpful, because that's then countered against the terrible restrictions that those living in care homes have faced. So some of them have not seen the people closest to them in person or at all since March. And I think to anyone in the country who's struggling with the impact of COVID and the restrictions, that as a challenge is just absolutely staggering. And I think trying to then understand how you move from that and say, well, how do we restore life and family life and supporting people? You have to do that knowing that people are going to be as safe as possible. And I think trying to gather the evidence that helps support policy making is really, really, obviously really helpful, but particularly timely like this, where there are public pressures to say, well, think about young people, think about children, think about this group, think about those working. Like, everyone's got a stake of why they are the most deserving group. But I think seeing that put together and saying, well, actually, this is going to make a difference, and this is hopefully going to redress. It will never make up for all of that lost time, but if we can rapidly move to a way in which we can reconnect people safely, that's clearly hugely advantageous for those who, and for the ongoing need of the sector, and the fact that we need care homes and that they provide such a vital part of the health and care landscape. It's really important that we don't do anything that sort of puts that at risk.
Thank you. And so I'm going to ask you now a bit about your experience as a training geriatrician and working as a clinician during the pandemic. You have told us a bit about the experience, and I have to say I'm at awe at how much you've managed to do that and do all this research at the same time. What's your feeling about what has been learned in terms of managing COVID from the beginning, and especially in very old people?
I mean, certainly from the amazing way in which we've mobilised evidence generating at the same time as clinical care with the recovery trial and others has been really quite astonishing. Because I think as clinicians, there's a sort of tendency to feel that doing clinical trials in particular has been very onerous in the past, and I absolutely take my hat off to the people who've really put the effort into doing that, because we've seen that change practice with the iterations of evidence gathering, and it's been something that as clinicians they've really made sure that everyone's involved with. So it's everyone's job to ask about research and ask about participation, and as a department we've been very passionate about making sure that our older patients are included in that as well, and giving them that opportunity. And I think going forward that's a real positive in terms of how the NHS and academia interact, is that actually we're all better when research is taking place in practice, particularly when that's got a focus and a purpose about improving care. Clinically, things have been very challenging. It's an absolutely unprecedented situation, and I think the duration of it is particularly difficult in terms of just wanting to restore some normality, wanting to get back to doing what we feel all more comfortable with, but at the same time pausing to reflect how much we have learned. I think the thing that we struggle most with, particularly for our older patients, is that isolation and lack of visiting, is having to update relatives and keep them up to date by phone, and that disconnected dialogue. And I think particularly in end of life situations where visiting is still unfortunately restricted, those conversations, so spending time with patients in high dependency with their family on the phone, talking to them, knowing that that's their last conversation. If someone had said to me that I would be standing in a room holding an iPad while someone said goodbye to their loved one a year ago, I wouldn't have believed that was possible. That was the kind of medicine that we practice. I know why we do it, and I absolutely think that it's been good that we've embraced the technology and that people are having that opportunity. But my goodness, it's not the kind of medicine that we want to be doing and the kind of care that we want to be providing. And I think any one of those examples, you just think it's so heartbreaking. You just don't want anyone else to have to go through this at all. So yes, I mean, I think in the older patient population, clearly recognising that COVID looks different, like almost everything else looks different, was a key changing point in terms of how we've kept people or tried to keep people safe and improve our recognition. But it also does make it that bit harder to know when someone's getting better or worse, and just trying to support people and support the uncertainty of the virus as it evolves through individuals. But we also have our successes, and it's great when you see people going home and returning back to the life they want to be living. So it's not in any way to present all doom and gloom. It's tough, but we know why we're doing it, and I wouldn't be doing anything else.
Thank you. And so we're talking, today's the 19th of January, so we're at this strange time. I don't even know whether there's a second or a third wave. And I just wondered if you could give us a bit of an update on the current situation in care homes in Scotland in relation to COVID, in terms of infections, in terms of how the morale in the sector, and perhaps to end up with a bit of hope on the deployment of the vaccine.
Yeah, so Scotland's really made huge progress in terms of understanding the evolution of cases, in that there's been the development of an electronic tool, a safety huddle tool, which allows care homes to submit data on a daily basis about the state of play, really, so to understand symptoms, outbreaks, understand the pressures that they're under in terms of the number of residents they're supporting who are approaching the end of life or need one-to-one care, understand interactions with hospital. There are still a considerable number of care homes experiencing outbreaks, although the trend is that those outbreaks in the main have been different to those from wave one, in terms of both their recognition and their size, although we're still trying to look at that in a more formal and quantitative way. It won't surprise you to know, to try to really be able to describe things as a whole. I think it would be safe to say that the sector is still under huge pressure, and that balancing of keeping residents safe in the home and keeping those safe who may be in hospital or may need to return is an ongoing and really huge challenge, because we know that we want people to be in their home. We know we want them to be around those who care for them and who know them the best, but we also need to know that they can be supported and that the pressures of those transfers can be maintained in a safe way. And I think it would be safe to say that there needs to be an ongoing and sort of much more mutual dialogue about how we best support people across, as I said before, that whole landscape of care. Scotland has changed through the pandemic in terms of oversight and structure, and there are a lot more things in place to try to support individual services and try to identify problems early and provide mutual aid in terms of staff in just the same way that the NHS is having to do. And I think there are a lot of parallels in terms of the challenges in the sectors, and in some ways it's getting both to realise they're both systems under strain, and just make sure that that is always maintained and the person in the middle of the process is kept at the heart of that. as you say, vaccination is going well, and I would, I guess, pay tribute to a huge number of people, particularly the Chief Pharmaceutical Officer within the Scottish Government, Alison Strath, and others, who've absolutely been committed to making sure that care homes are the top priority, and that we can do things as systematically and comprehensively as possible. It's interesting, some of the logistical challenges around giving out the vaccine have created their own burdens in terms of who the MHRA are happy to hold vaccines and who therefore can give vaccines. And I think it just betrays, unfortunately, an ongoing lack of understanding centrally of what social care is all about, what care homes can do, what care home nursing can do. But we've learned to live with that, we've worked around it, and I think going forwards, we recognise that there's an awful lot of people who need to know more about social care. But the success has been that, as we stand at present, that more than 80% of residents have been vaccinated, and the staff uptake is good. I think there's an ongoing need to continue to support staff to help show them that we think that vaccination is safe and that it's something that they should want to participate in. It's unfortunate that there's been some campaigns specifically targeting them with misinformation in Scotland, but Scottish Care and other organisations are working really, really hard to make sure that that's countered and that you really promote vaccination as the positive, huge game change thing that it really is. And some of the individual care homes have done really well with that, particularly on social media, promoting and just celebrating what this means moving forward. So yes, I think a huge success.
That's very, very nice to hear and to reflect as well on what we're learning from all these logistical challenges. And I'd like to end just to ask you, so if you're looking to the future and we say pretend COVID is gone, what is it that you think we've learned from this experience that can lead to improving the way that care is provided to people living in care homes particularly? How do you see things changing, and what do you hope that we'll be able to carry forward as improvements?
So it'd be lovely to think about the world when COVID is gone. That's very welcome. So I think fundamentally it's no longer acceptable for us to know as little about those who live in our care homes and those who receive social care as we have done historically. And I think you won't find anyone who now thinks this can be left or this is in the too difficult box. I think people are recognising that yes, it is difficult, it is challenging to try to understand a sector that has so many different multiple individual stakeholders and moving parts, but that actually it's just not okay not to know. And the benefits from knowing are huge. They're huge for all of us, whether that's as those who may wonder if we need care later on, understanding the pathways and the journeys, whether it's those who are in that situation making decisions, supporting their relatives, whether it's those living in care homes and how we provide the clinical model and support that best allows them to receive care and the care that they deserve. I am very hopeful. Certainly in Scotland, it's brought a lot of the key individuals and stakeholders and groups together, and the conversations now are about how things are going to be different rather than why they haven't been done or why it's been difficult in the past. I do think technology plays into that in a big way. So the Safety Huddle that I mentioned is an online platform that's been designed in the midst of the pandemic, is live, is now accessible in every care home in Scotland and for all the oversight groups. Daily data was not something that anyone would have thought possible with the technologies that we had before. So I think there's huge potential there, but what we have to do is just get back to the focus on what's important to look after those who live in those settings and those who work there, and what do they need and how do we evidence that, and making sure that then anything that we're asking to be done from a data point of view draws actual benefits to the people on the ground, and isn't just about measuring things for the sake of measuring them. It makes a difference. But I do believe that improving the data will help us to improve the resource, the support, and make sure that we are actually serving people better, and allow us to understand where care homes fit, how all these different models of care fit in, and make sure that actually we're organising our services in a way that helps improve outcomes for the individuals. and I'm absolutely committed to working towards that moving forwards.
Thank you very much, Jenny. That was great. Thank you.